Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. Here at Doc Buddy, we deliver healthcare solutions that take the pain and cost out of broken workflows. From the ASC to the clinic to on-call at the hospital, Doc Buddy helps providers create and move data seamlessly, all from the point of care. You can learn more about us and our solutions at docbuddy.com. And today we've got a great guest, Michael McClain, founder of Left Coast Healthcare Advisors. He has 20 years experience in healthcare, including time as a hospitalist PA, and he's held leadership roles in several large and small healthcare organizations. He's also a nationally recognized speaker and frequent contributor in the ambulatory surgery space. Michael, we're so glad you're contributing to the Doc Buddy Journal today. Thanks for joining us.
Thanks for having me, Eric. This should be fun.
Yeah, I'm looking forward to it. I know we go way back, our organizations do. Before we get into sort of the meat and potatoes of the episode today, we were just talking about the TV show The Bear. So before we get to that point, what else should listeners know about you?
Oh, I think I'm the poster child for not figuring it out the first time. I had a few different pathways to get here. I never thought I'd be a consultant in this space. And I think that's pretty reminiscent of a lot of people in the ASC industry. Maybe you started in hospitals, or maybe you started as a nurse in an ER, and a lot of us kind of migrated here. I talk about sometimes the ASC industry as hospital refugees, and we migrated into this space because it was fast moving, and you could make decisions quickly, and you get to be the chief cook and bottle washer. And so, even though I guess you could argue, at a point in my career where I could do a lot of things, I'm still here because this is fun. But I certainly didn't start here. I didn't think I'd be here. So
I haven't heard that one, refugees from the hospital. And that kind of ties in. I've had a number of guests in recent episodes that have come on to talk about leadership and culture at the ASCs. And it seems to me as an outsider, I'm on the vendor side of the ASC space, among other places of care. But sort of a common refrain is that you have an administrator leave and, hey, we've got this great charge nurse or director of nursing or this person in our ASC who's never held a role like that, but they're the one. That's who we want to lead this organization. So that what you just said makes a ton of sense and kind of crystallizes it for me.
Yeah, absolutely. I was a PA running a hospitalist group in a large Catholic health system and had some buddies who were orthopods starting an ASC who said, you want to leave that hospitalist practice and help us? And I'm like, I don't even know what an ASC is, but too many nights and weekends, and my wife being a trauma nurse, I never saw her. The idea of, what was sold to me, which all of us as ASC administrators know was not a 9-to-5 job. But what was sold to me as a 9-to-5 job seemed pretty appealing at the time. And, 20, 25 years later, still doing it.
Well, and what you just said, didn't even know what an ASC was. The common refrain from our good friends at ASCA and all of our state associations is that awareness around the ASC is one of the biggest hurdles to this very rare win-win-win in healthcare. And that's kind of a nice segue that part of the reason we're speaking today is that you will be leading a session at CASA, which is the California Ambulatory Surgery Association.
Yeah, one of the great West Coast ASC conferences. I'm doing a small session on financial improvement in operations for ASCs. We love being at CASA, being a West Coast organization. We have a lot of friends in that space, I would say, former colleagues, current clients. But if you're going to hit one conference, CASA is it, and that's the reason that we go. We support it heavily. They do a great job. So if you're free, man, get down to Anaheim. It'll be fun.
Can't speak highly enough about the organization. April Leitenberg is absolutely incredible at what she does. So just want to reiterate that September 4th through 6th, we'll get a link to the association in the show notes so that if you're out west, or heck, even if you're not, you've got a chance to get signed up. It is just a few weeks away, September 4th through 6th for CASA. And Michael, I know one of the core focuses of our talk today is really around awareness of what you're doing, being able to look holistically at a plan. for your ASC, for your facility before we started to record. You said something that really rang true to me, that if you're planning to do more at your ASC, more of what you're already doing is just more. That scales pretty readily. But if you're going to be doing something different, that's not just more. So let's dive into that a little bit if we can.
Yeah, no, I'd love to. And, I would say probably the question we get asked the most, and not just as consultants, as colleagues, or you're sitting at dinner with a friend whose husband or wife is a surgeon, and well, we're thinking about adding this. What do you think? And like I said, adding more of the same, you can scale. You know what's happening. Maybe you need a few more nurses. Maybe you need a few more trays. I mean, it's a little more predictable. Adding new service lines brings this complexity of changes in payer contracting and reimbursement, and how does it impact anesthesia? How does it change your workflow? Maybe new offices, new equipment, new vendors. And the tendency is to focus on best case scenarios rather than worst case. And unfortunately, the reality often is it doesn't go as fast as you hope. It's not as easy a transition as you'd planned. Reimbursement doesn't turn around as quickly as possible, and it creates more headaches the first 2, 3, 4, 6 weeks of service. That I love auto racing, in particular, not Formula One, not NASCAR, but like nitty gritty SCCA, like running around in corners with loud, kind of slow cars. And the key to being a great racer is going slow, is understanding the track until you really get comfortable with it, and then laying the hammer down. And I think the same really applies as you grow your business, which is sometimes you got to go slow at first to really understand the landscape before you can really go fast. And so we really push our colleagues, friends, clients, much to their chagrin sometimes. They want to go faster. But you really need to do some of that slow down, check all the boxes, and then hit the accelerator.
We didn't plan this out, but Michael, once upon a time, you'd have been surprised to hear that I was one of those guys, going through the cone track, in a relatively slow vehicle. And you could always tell the contenders, because their first lap through was, as you described, nice and slow. Let's get a lay of the land. And then subsequent laps got faster and faster and faster. So that's wise words. Good crossover there. Good carryover.
Yeah, if it's got four wheels and a loud, preferably 8-cylinder engine, I love it.
Yeah, you and me both. To bring us back to our focus here, one of these new things for the ASC, or relatively new, are cardio procedures coming off that inpatient only list. So for some facilities, that's going to be very, very new. And heck, even for your surgeons, your cardiologists, it's going to be new performing these procedures in the facility. That news has sort of died down a little bit. We're going to talk about AI and healthcare, towards the end of our show here. But at the beginning of 2024, cardio off the IPO, that was, big, bold font across all of the news sites. What's happened? What's changed? What's coming? What do you see?
It's interesting, and this is kind of gives me a little bit of opportunity to lean into that clinical background as a hospitalist. Is that many cardiovascular services, in my mind, both clinically and operationally, fit super well into an ASC. They're predictable. You have a reasonably low comorbidity. Now that you have Medicare removing some of the restrictions, taking them off an IPO list, allowing for ASC reimbursement, there's a lot of opportunity there. The challenge is it's a very different specialty than your typical surgical specialty. And so from a clinical management standpoint, it requires a lot of change, not just in the equipment, to be able to image the heart, image the vascular structure and anything you're placing in there, but the education and training of your nursing staff. Quite often rhythm management, especially if you're looking at EP or things that are going to potentially impact the heart rhythm, become a much higher priority. And, ASC nurses are awesome. My wife was one for, 15 years after her time in the ED. But it's a change it's a change in your work style. you move back to that world of I got to pay attention to the monitor all the time. Um, but the bigger picture probably is that Medicare is ironically one of the most progressive payers in the land on this space. They're saying, go forth, begin these services. And yet you still have all the various regulations by state that may limit, restrict, or completely disallow cardiac services. And so, understanding what you can and can't do, how do you slowly bring it in? Just like we did 20, 30 years ago when we started to bring heavier ortho or spine. Start small, get really good at it, add procedures as you go along, and build the muscle to be able to do it well. But it's definitely the rage, but also brings a different reimbursement. It brings a different case mix and payer mix because you tend to have patients that are a little bit older, a little bit sicker, a little bit different payer mix, maybe a higher mix of Medicare, Medicaid. And so some of the standard assumptions that you'd make, hey, I want to add knee scopes. I want to add this. You got to make sure you're touching on all those different drivers, about what's the reimbursement? What are the changes to your staff and training? Because it's going to look and feel different. Doesn't mean not doable, just means might take a little more time to get in place to be able to really pull the trigger.
Well, and to that point where Medicare, I guess let's call it CMS, Medicare and Medicaid are saying go forth and perform these cardiac procedures in the ASC. This is not meant to be a conspiracy theory podcast, but a lot of my background is on the clinic side of EHRs, where meaningful use was, very well intentioned. And I think our outcome has ended up pretty good if you look at it holistically for patients and providers and payers. That was really painful, though, 15 years ago for a lot of clinics. So, do you see a future where Medicare is saying, yeah, let's unleash all of these procedures to the ASC? That way we could maybe get some data. So, I don't want to call it meaningful use part two, but meaningful use for the ASC seems kind of like a logical next step.
One of my biggest criticisms over the last 20 years is that ASCs have been left out of that meaningful use, both data tracking and funding to allow for additional digital documentation. And that's really left us as an industry 2 or 3 steps back. I mean, all you have to do is go to a conference anywhere in the country and ask the folks that are drifting by a booth, do you have an EHR or are you using paper charting? And, it's still, I've heard numbers as high as 50, 60% of ASCs still on paper charting. I don't know if it's still quite that high or if it's moving backwards, but I think, or moving progressively forwards, depending on how you're looking at it. But I think that there's absolutely the opportunity to be able to capture that data, to be able to present outcomes. I think the challenge that ASCs always have and will continue to have until there's a more of a formal, meaningful use push, though, is that we provide services for a moment in time, which is that episode of care. And the real value in the data is 30, 60 days down the line, or sometimes even 7 days down the line. Did your patient discharge, go home, go back to their community and go visit a community ER and they didn't tell your surgeon and they didn't tell you? I think that's the missing link. And I think once those pieces can be connected, ASCs can surge to the front in terms of both data and outcomes, because it's more than just the episode of care. It's the total outcome. But right now, because of the failure, I think, of the federal government to help provide a pathway to get us compensated, we're playing catch up. But I think this is a great way for them to say, here, go prove yourself. It's unfortunate that it still means most ASC investors are writing paychecks, writing checks to get the data.
Sure. And to be fair to the ASC space and our physician owners, among other stakeholders, if you've already bought 4 or 5 or 6 softwares, EHRs for your clinic, and if you found one you liked, you wouldn't have bought the next one and the next one and the next one. It would be really hard for me to, if I put myself in the shoes of the surgeon, to go, yeah, let's go spend another 6 figures. And I don't just spitballing here. There's only so many options on the ASC space, but let's go write another 6-figure check for something I don't want to use, I don't have to use, and nobody's telling me to use. I mean, that's
100% agree.
tremendous value through that supply chain or stakeholder chain at the ASC. So pre-op, post-op, PACU, but then you have the surgeon who, in general, is sending off dictations to be transcribed that come back as paper. That's a tough sell. I do not envy our friends at the major EHRs in this space.
It's a really tough sell, and what we have to remember about most physician investors in an ASC is that their primary business is their practice. Their primary business is not the ASC. ASC is in other than situations where they have a really valuable ASC, which there are many of them, but many physicians really look at the ASC as a secondary source of income. And so it's offsetting the beating they've taken on the professional side. And so it's harder to maintain a second business with 90 or 120 or 180 days cash on hand, and to reinvest in technology, both in your primary business and in a secondary business of which you might only be a small percentage owner of. And so I think that the balance of the scale when it comes to investment and technology in the ASC space starts to lean towards how do you better utilize what you have versus scrapping and starting over again and again. And I was recently at a conference, and I was asked the question about what EHR do you want to drive to, or what's your choice? And I'm like, my first question is why? What are you not getting that you need to get? Figure out the workflow first, then go shopping. And unfortunately, sometimes I think it goes the other way. But understand what your needs are before the pen and checkbook or the EFT comes out.
Well put. That really lays it bare, and that's one of the talking points we wanted to cover, is looking at drivers around different factors before acting. I know one of the ones we kind of flirted with it to this point, but reimbursement as a driver, sort of as the baseline assessment for any ambulatory project. So either reimbursement or ROI. And I had it put to me this way by a physician that there can never be ROI for a software because it's not an asset. It's just something that you pay for on a P&L. And I thought that was pretty witty. It has stuck with me. But when you're looking at reimbursement as a driver, as the baseline assessment, what are some of the pro tips? What are some of the pitfalls that you see and help your clients avoid?
Yeah, especially when it comes to growth. I think the baseline comment is it's the most important piece of your business, how you get paid, how much you're paid, how quickly you're paid. It should be one of the highest focus points of your administrative service model, which is how you get paid. And so it takes a lot of resources, whether it's rev cycle, payer contracting support, et cetera. So understanding what you get paid and how you get paid should be your first priority. If you understand that, then you've put together, and most ASCs are actually quite good at understanding what they get paid for the services they have. As you think about adding a service, then it becomes, okay, what are we realistically going to get paid with the new service? And understanding that your existing agreements might not cover new services. Or if they do, maybe it's only a portion of it. Maybe it's going to require changes in billing. Maybe it's going to require changes in how you manage your claim submission because there's either new rev codes, new exclusions, et cetera, that you have to understand. And the one that I see gets missed all the time is, even if you're pretty confident you're going to get paid, it still quite often will take 30, 60, 90 days to get the first payment for the first new procedure, because it's a new claims process, especially if you've had to change something on a contract. It takes a while. And so it's not enough to just make sure that you're getting your costs plus a margin. Everybody asks me, what's the best rate you can get? Cost plus a healthy margin. Should never accept cost as a reimbursement. I mean, you can't reinvest in your business. But even if you've negotiated, you've done your homework, you know what you're going to get paid, you've maybe added carve outs, whatever, you've got it ready to go. It's still a process, an administrative process on the payer side. And so you may take 90 days to get that first payment processed correctly. And there's nothing worse than you just bought a bunch of equipment, you've staffed up, you've got a lot of educational costs, you've just put a lot of money into a new growth area, and those checks aren't coming yet. And so being able to budget accordingly for how long it takes to support that new reimbursement model coming in, being aware of that and just getting it in the budget, plan for it.
And by the way, if I can be so bold to add to everything that you just laid out there, all the waiting you've invested in X, Y, and Z place. And by the way, you don't have the staff to be calling that payer daily or failing daily, weekly to ask, where's our money? It's in black and white here on the contract. Where is it? That is a critical component to this game. And staffing is just so lean for surgery centers now.
And it's gotten, unfortunately, in many communities, especially on the West Coast, where so much of our labor costs are driven by our tech brethren. No offense to the doc buddies on the call. But it's really had an adverse impact on salary and wages in tech hubs. And so, I'm Seattle based. A lot of my clients are up and down the West Coast. The labor drivers on the West Coast quite often aren't, ASCs used to compete with hospitals or used to compete with other areas for labor. Now they're competing with Google. Now they're competing with Amazon. Now they're competing with other much higher compensated clinical folks. And so to keep your staff, you're paying more and more money. So those staffing shortages are more pronounced, especially in the West Coast. And you're right, we're already lean. I mean, we pride ourselves at being lean. But during times of change, there's still a labor intensity that has to be applied.
Yeah, there's at the end of the day, there's a lot that can still be automated for ASCs in general using technology. But I've heard it put this way, medicine is a hands-on business. It takes people. You cannot have machines doing everything or software doing everything.
Right. The software is a tool. And it's how you apply it and where you apply it that can really open the door. But it has to be driven by sort of the knowledge of the workflow in the first place.
And continuing down that path, one of the other things that you shared before we started to record was around clinical drivers, focusing on patient requirements, evaluating service demand. I mean, to me, what we just said, you're asking about market research. You're asking a facility to perform market research to a degree. How do they do it? Who's going to do it? And can you have a reasonable expectation for timelines?
We talk about how do you understand your market, and I spent a number of years doing payer contract negotiations directly for large and small ASCs for hospitals as well. And, a lot of what drives the market is what your neighbor is or isn't doing, and what they have or have not agreed to get compensated for it. And so you in a new market, in a growth area, you never want to be the last person to add a new service line. You want to be the first. Well, you want to be the second. Let somebody else work out all the big kinks and you come along in the second position. But you're absolutely right. As an ASC, you're an administrator sitting at a desk and you're trying to understand, how do I figure out who else is doing this? Because the internet search may not be helpful. There's no shortage of vendors online that you can reach out to and say, hey, can you give me information? And everybody will, but can you really cull through that information? Do you have the time and resources to get through it? And so it becomes really difficult to understand the market. Your surgeons still are quite often your best divining rod for where the market is going. Because they're seeing what their colleagues are doing. They're talking about what's happening in their markets. But again, you have to carry that with a little bit of a grain of salt, because it's still about the reimbursement marketplace. Because if everybody's doing something, you're going to add toenail removals. Let's pick, it's a new fancy way to remove toenails, and everybody's doing it. chances are the payers have caught on and have already artificially depressed the reimbursement for it because someone didn't do the homework that you're doing right now, and they took a rate that's below their cost. And now that's being touted as the standard. And so that's why sometimes you really want to move fast, but it's worth it's there's great technology. We've worked with some of those strategic data consultants that can bring in, with hospital transparency data and payer transparency data, you can get access to base contract rates for other facilities through some of these vendors, but those are imperfect. They don't include things like multiple procedure logic and things like that. But you can get some data, but nothing works as well still as picking up the phone and secret shopping. I want to get my knee done. I'm seeing Dr. So and so. Can you give me a price quote? And have your staff call from their cell phones, do a little shopping, see who's doing it. It's silly, but it's still sometimes some of the best information that you can get. And then you weigh it out.
Well, you kind of hinted at this, but that very first step of any facility or any venue of care's revenue cycle is contracting and credentialing and enrollment. And the contracting, you look at that and you go, I'm not a lawyer, I don't know what to do with this. I guess we'll just take whatever they offered. You can't do that.
You really can't. Quite often if you understand, and I spend enough time in this business, and we talk about this quite a bit, that the folks that we engage with on a day-to-day basis from a payer contracting standpoint are not ASC experts. It's a little bit of an ego hit when I say this, but it's true. ASCs were a drop in the bucket from a reimbursement standpoint to a payer. We're not nearly. We don't. We're gaining visibility, but the dollars involved in an ASC aren't nearly as large as the three hospitals in your community and the four large medical groups. I mean, those are multi-million dollars per payer per year agreements, and we're arguing over $200,000 or $300,000. So the resources that are provided to the people that you're talking to on the phone at the payer are commensurate with the scale of your reimbursement that they're providing to you. And so they are not ASC experts either. They have a template, they have a bunch of contracts, and they're paid the same way that you and I are paid, which are here's your targets, please go get them. So it takes getting a really good relationship, if possible, with your payers to educate them about what's the difference. Why does this matter to me? And understanding your cost, your true cost, not your ideal cost, not the, I think we could do these in an hour and with only one implant. That's awesome. That's at full speed, full scale when you get it figured out. The first few months, what if you're doing it in an hour and a half? You're using two implants, and that's extreme. Some people are like, I do that in 30 minutes. Okay, 30 minutes and five implants if you're talking shoulders. I mean, but use your math, but plan for the worst case and get those costs covered because you're still going to run into those situations and provide that information to the payer as here's why we can't accept $12 for this total knee replacement. And we need to have a better mechanism. But it takes reading the contract, and sometimes it takes an expert. There's us, there's others. Sometimes it makes sense to reach out when time or resources are short on your side. And that's okay. But in the end, really understand what you're getting paid, and push back if it's not covering your costs.
And is Michael, is part of this pushback when you've got a client or it's yourself on the phone with a payer and they're offering that $12 on that procedure and that's missed the mark by 800% or whatever it is? Is any part of this conversation like, hey, I understand what you're looking at here seems right to you, but this is better for you and your business as opposed to me saying no. And now you've got one less option and you're going to end up having people funnel into the HOPD and it's going to cost you 1,800% more than what you just offered me. So can we true this up?
Yeah, and the best, you're absolutely right. That's the approach. In our experience, it's all about the timing of when you have that conversation. The time to have that conversation is before you ever do the first case, because you're offering a savings. You're offering, the ability, and I say this all the time: grab some EOBs from those patients at those hospitals that are your physicians. Have your physicians talk to your patients, understand the costs they're paying at the hospitals for a particular payer, and share it back with that payer. It's not a HIPAA concern. It's the payer information about their own cases, and being able to say, listen, we have EOB evidence. We know it's $47,000 a case that you're paying. We're offering you the opportunity to save $20,000 a case by partnering with us. And here's our outcomes. Here's our docs. Here's the volume. Here's the very specific. Here's the value we provide. The worst time to do that is you've already done five and you've accepted, $5 for each of those procedures, because in their mind, they're like, hey, we saved our money by paying you $5. And honestly, by doing the case, you said that the payment was fine. So why should we make a change here? And so it's timing when you have those conversations, timing around terminations, timing around contract negotiations, making sure that you give yourself the most leverage in a conversation. Mid contract, new procedure, I want to add one code at a new facility and I've already done it 4 times. That's about the least leverage you can ever have in a conversation with a payer. It's coming up on contract renewal. I'm going to move 30 new cases. Here's the data I have. And I'm considering terminating this contract if I can't get a reasonable rate to help move these. Oh boy, you got way more leverage now for that conversation.
So I don't want to say any of this sounds easy, but I also don't think any of it sounds hard if you're one or two steps ahead and you're not afraid to roll up your sleeves, get the data, and have, to a professional like you, it's not a hard conversation, but to some, it might be a little daunting to negotiate and, run up to some adversity is the word I'm looking for. Is that a fair way to look at it?
I think it is. And it's time. It takes a long time, even as a professional negotiator. Premium contracts to get a premium rate might take 6 months of negotiating and 3 or 4 back and forths and data. And it's really hard when your physician's like, I want to add this next week. And you're like, but it might take me 6 months to get a reimbursement rate that's adequate for this. And so this comes back to that sort of operations drivers, is that, well, you know what? We've looked at our contracts. We can do this for this payer. You can start bringing your Aetna cases right away or your United cases right away. It works. These cases don't. And we have to find an appropriate reimbursement for these cases. So understanding and segregating their operational process in the office, it's hard, it's inconvenient, but in an ASC world, convenience is the killer of profitability. If you're willing to inconvenience yourself, you can do great things. We talk about there being a cost to the cost of convenience. As you're adding new services, there's a huge cost to convenience. And so understanding there's going to be time. So build that into your new services, understand where you are in your contract negotiation terms, who's up, who's not, and plan ahead.
Well, and in that vein of convenience, one of the very hottest topics we talked about cardio in the ASC kind of dying off a little bit in terms of news coverage. A topic that hasn't died off at all and is only gaining momentum is AI in healthcare. Artificial intelligence in healthcare can mean a lot of things to a lot of different people. One thing is certain, though, it's appearing to be here to stay. What are your thoughts? What are you seeing on the front lines, Michael?
Well, if you swung by my LinkedIn profile over the weekend, I was talking about Skynet. So, for those of you who aren't as old as I am, the Terminator, Skynet taking over everything. Yeah, that's a little bit of fear mongering, a little tongue in cheek there, but I 100% agree. AI here to stay. You know, an artificial intelligence, whether it's automating your existing practices, having decision making happening, not going away. I think, though, what's really important for any new technology and one that has a decision making component that matters, um, it's a tool. It's got to be a tool in the toolbox. It cannot become the contractor. It needs to be the tool. And so there are plenty of things. I almost don't take a position on whether it's good or bad. I think that if automation and artificial intelligence decision making is surfacing the information quicker, that helps you make good decisions. If it's accurate, I'm a trust but verify guy. Double, triple check the data as it's coming in. Does it make sense? Does it, this doesn't look right? Well, go dig in, make sure it's real. But if it's helping you offset difficult, labor intensive processes to get you information to decide, 100% on board, ready to do it. It's also a buzzword as a shortcut to process improvement. And in the end, that improving your workflows, improving your processes, I mean, that's something that we're pretty adamant about, is that figure out the ideal process first, then automate it. Don't automate what you have. There's this old term, I grew up in Michigan. My uncle was a dairy farmer, and he used to talk about paving the cow path. Is that, the worst thing that you can do is just pave the cow path, which is the cows know where they want to go. They just go, and then you just pave it, and then you end up with this farmland with, all these strange concrete paths around. I think IT is the same way when we start thinking about adding technology, is that you want to blaze a trail, you want to find the right way to do it, get your workflow dialed in, find the path that makes sense, then hardwire it with automation and technology. Don't just pave the process you have today because someone can. And I think, this is something where there is literally a vendor a week that's reaching out to us, and I'm not even buying. So I can't imagine what ASCs and hospital leaders are getting bombarded with, where I got a solution for you. It's great. It's going to solve all of your problems. It's only $9.95. It comes with a free clear code. I mean, then it's not to pick on the vendors themselves, but a lot of times it's automation of processes that were never applicable in the ASC space in the first place. So you really need to, first of all, find somebody else that's bit on that to see if it's working for them, but do the homework to figure out what you really need, then apply automation and AI. And, once the Terminator's here and Skynet's here, it's all over anyway. So we can't really stop the progression. It'll never stop. It won't stop. It won't ever stop. And sorry, I'm a sci-fi fan, but it's here.
Well, those are wise words there. And just to your point about the bombardment of AI across all facets, I'm at least my inbox is still in the phase of the thought running through my mind. This vendor has people paying for this. Like, what does it even do? They're paving cow paths all over the world. There's still some very good stuff that's out there, but there's also a lot of AI, and I'll use air quotes there, where you just think, who asked for that? Why did you build it? And I think the health
Yeah.
community needs to be able to separate the wheat from the chaff, to use our farming analogy here. A lot more chaff than wheat today.
And there's a lot of organizations, a lot of companies, shameless plug for Doc Buddy and others that have been around for a lot longer than I think people recognize. And I think starting with those vendors you've worked with, that that have been in the industry for a long time, most of them aren't afraid to have conversations. They're not afraid to give you way more information that you need. They're not afraid to help supply lots of examples of other people using it. There's a lot of transparency. There's a lot of pride. There's a lot of sales, but there's a lot of transparency in about what is being offered. If it's, you know what, if you sign today, we can get it built and get it in and get it quick. My opinion is run,
Totally.
because this ASCs, if you asked me 5 years ago, this is a metric we used to run when I was still working for Providence over all of our ASCs. What was the average EBITDA, the average profit per OR per ASC? And if, 5, 7 years ago, that EBITDA might have been, a 500,000 per OR per year on average. The cost to build was half of what it is now. Now you're talking, $800, $1,000 a square foot build cost, $1 million in medical equipment if you're doing heavy ortho. This is a 10, 15, $20 million investment you're making a lot of times in your new businesses, and you're running 30, $40 million of revenue up front. And we're still have a chief cook and bottle washer who is a professional firefighter who's trying to make the best decisions possible based on what's in front of them. We need to support those people and having the opportunity to get good information. And sometimes that means, more information like this at conferences, more industry connections, but giving them the opportunity to take a breath, slow down, and really get information, because these are huge multi-million-dollar businesses that we're running, and you can't just make a decision based on what you saw on YouTube.
Michael, where can people get more information about you and your work? Where can they find you online?
So I would encourage people to stop by our website, Left Coast Healthcare Advisors. It's lchadvisors.com. Just Google Left Coast Healthcare Advisors. We're the only one that comes up. Drop by and see our LinkedIn page. You can always see me on LinkedIn. If you're going to be at CASA, we'll be at CASA. We'll be at MGMA. We'll be in Boston and Waltham. We're going to be all over the place in October and November as well. So good online presence, and hopefully get a chance to see some folks in person in the next few months.
I can't encourage you strongly enough to attend CASA if you are a West Coast or a Left Coast ASC facility. And we'll, of course, have links to all of those places in the show notes. And on behalf of the entire Doc Buddy team, I want to thank you for listening. Michael, thank you for joining us. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so you can always get the newest episodes of the show. And until next time, I'm your host, Eric. We'll talk soon.
Thank you so much, Eric.